Thank you so much for inviting me here today. This is the most fantastic venue I've ever been to, but I'm very interested to have heard Marie just speak there and look at the differences between now and 17 years ago, because I think that's roughly about where I started thinking about neonatal palliative care and how we can move forward. And certainly we have moved on nationally, internationally within that time. There's always space for more work to be done, but I am very warm to think that we are moving in the right direction. And I think there is a united view and vision that we need to be working together. We can't be working in isolation. So it's across services, it's across statutory and non-statutory organisations. And just a little bit about my role now as the Pan-London Lead Nurse for Neonatal Palliative Care. It is primarily charitably funded by the True Colours Trust in England and Chelsea and Westminster Health Charity, with a small proportion of funding coming from an NHS hospital, so I'm based within there. Obviously the future, once this project is completed and we've evaluated it, we're very fortunate to have had funding for 5 years, and that finishes into 2020, is that it will become absolutely embraced by NHS England. That's a huge ask, but that's where I'm hoping we're heading, because there is a huge reliance on charitable organisations, and that's nationwide and internationally, that we have to work together in some way. So why is neonatal palliative care different? I'm not going to go too much in depth because I think we do know, but of course we are looking at new members of families emerging. And when we talk about neonatal palliative care, I don't just mean those first 28 days of life. We are considering and bringing in the antenatal phase, the perinatal aspect, right through to children's services. It doesn't just end on a neonatal unit. But certainly with the advancements of technology, babies are living longer, and then going on to talk a little bit about transition into adult services as well. So, of course, there's been huge media interest, and that continues to drive us with miracle stories, sensationalism in the papers, sensationalism on TVs. So, in fact, it's becoming everybody's business. People can see this. The normal person out there who isn't within the health profession always has some kind of knowledge or some kind of awareness what is going on. And we do have an absolute duty, I believe, to think about advanced care planning and think as early as possible about how we can incorporate all the services that these families and babies need. So it isn't just thinking about the immediate time within the acute setting, whether it's antenatally, whether it's in the hospital, but obviously thinking about this baby going home, or this baby going home after death, and how we can facilitate that and help that to happen. And again, referring to what Marie was saying, just about the advancements that can happen now. And certainly we need to think about how we're going to transport that baby, how we're going to support the family at home. Often there aren't the community services available, but possibly we can work together and share some of that care. So just as I said, it's thinking as well about not just about the life, but it is also that continuing bereavement support for that family, however long that may be, and whose responsibility that may be. And sometimes it will fall within the community, it will fall within acute services, but certainly trying to make sure that the family's wishes are facilitated wherever possible. The remit across London, of course, is we're talking about 30 neonatal units across a wide geographical area with different services in each of those areas. Obviously, I'm sure here in Ireland, Southern and Northern Ireland, you will have the same challenges where services aren't equitable, and it is dependent on where the family live as to what services are available. But of course, we have to continue working together with the families, absolutely central, and the baby is central to all their decision making. But if we're not linking up together, then we can't provide the best possible pathway and the best possible plan for that baby. So the project came about because there was definitely there was a void, let's say, of thinking, how can we link everything in together? Well, it was decided that possibly with the help of a nurse, a senior nurse with the experience and expertise across London, that this could be possible. And again, not working in isolation, but networking and linking in the community services with the acute settings. So the key aims of the project were to reduce inefficiencies and delivering that consistent high quality care and developing smooth care pathways which are robust wherever that baby and family live. But again, key is the practical support for staff, the allied health professionals, everybody involved in caring for this family, because if we're not supporting the staff, then the staff can't support the families. And if the staff don't know what services are available, they can't possibly share that with families so that families can make informed decisions. And I think it's important that we do recognise that not every family wants to go home with their baby. For some families that might be really distressing, and they want the support of staying either in an acute setting, if that's an option, or having that shared care within a children's hospice. So it's about trying to support the family with their decisions and what they would like. And trying to develop an equitable service. We talk a lot about policy making and frameworks and recommendations and having some equitable service. It is a huge challenge, but I think we have to strive for that. It shouldn't be a postcode lottery, that it's dependent on where the family live or dependent on what study day a certain professional has gone on, whether they get that service or they get that choice. And I think, again, going back to the importance of having specialist palliative care services, but again, I really passionately believe that it is everybody's business to know what is possible and what services are available out there for families. So just to get a bit of context about London, some of you who've heard me speak before may have seen this, and this is a map of London, roughly within the M25. Neonatal services, neonatal units are divided into 3 sections, northeast and north central, up here, northwest over there, and southeast and southwest at the bottom. And within that geographical area, there are 30 neonatal units, and they're demonstrated by the pink dots. We have roughly a birth rate of 129,000, 10% of which we would expect to, of babies which we would expect to need specialist neonatal care. So that's not saying that all those babies would be having complex or palliative care needs, but certainly needing access to neonatal services. We're very fortunate across this geographical area that we have 6 dedicated specialist hospice services that we are able to access. Additional to that, we have 3 dedicated palliative care teams and 3 dedicated nursing palliative care teams. So we have a huge amount of resources across London, but many of my colleagues in London aren't aware of what those services can provide. So one of the remits of the project was very much of making those links, introducing community services into the acute settings and vice versa, so that people could meet each other and actually think, yes, I could pick up the telephone and just find out what would be possible, what kind of support would be able to be provided for a family living in this particular area. It's trying to encourage that collaboration in real terms. And whilst I'm very passionate about the importance of having policy, national guidance and frameworks, but what does it mean in real life? What does it mean for the nurses, doctors, social workers, play specialists, midwives, people actually doing the work? What does it mean for them, and how we can translate that into making sense? So, again, as I said, in England, we've got many new documents that are currently being revised. The most recent being the Together Fisher Lives document in 2017, earlier this year, was published with a focus on perinatal palliative care. And of course, we have the NICE guidelines, again published last year. But as always, it is the challenge about how those are translated into real life. So to develop this project, as I said, it was funded for 5 years, started in March 2015, so the funding continues until March 2020. It was the importance of having a point of contact, having a lead named person who would also be in an advisory role, to try and help that collaboration that we've talked about and heard significantly this morning, and networking across the services. And of course, education will be fundamental. It's not the whole remit of the project, but it is absolutely fundamental that we focus on training the staff and providing accessible training. Of course, there are always going to be different models of education, whether it is within the universities, whether it's online, whether it's face-to-face, and it will appeal differently to different people, and also there were always going to be those restrictions on time and funding, how people can access their training. But also to look at measuring against the guidance and the frameworks that were available, and an opportunity of sharing knowledge, recognising that there's excellent practice going on in a variety of places, but where do we get the opportunity to share that information together and think, actually, so-and-so's doing this over there, perhaps we can adopt some of the work that they're doing. Or it's having that forum of sharing, having that opportunity to talk about some of the families that you've cared for. Because often we are thinking on the job, and again, we have guidance, we have principles, but it's often each family, of course, as we know, is unique and will bring up different challenges when we're caring for them. But most importantly, we have to evaluate the project. So I'll just talk through a little bit about what the training sessions look like, and then how we're evaluating the project. So we built on the work from 2010 and 2011. It was a Department of Health funded project delivering training in 7 neonatal units, and published this article. So it's already quite out of date, but the principles remain the same. And the importance of collaborating with the neonatal transport team. How do we move these babies around London? Importance of collaborating with the children's hospice services, the neonatal units, and the organ donation teams. This has certainly become an area of great development within England about the possibility of donating whole organs within the neonatal population. So it's about trying to make we've got a shared vision and how we move forward together. And it's also, Marie mentioned the APPM formulary, how now the Association of Paediatric Palliative Medicine, their formulary, the huge amount of work that's gone into that over a period of years, of how we can actually adopt that. Everybody likes to use the BNFC for medications and dosages, but it's about recognising that we need to perhaps move away from everything being given via central lines, which we love on neonatal units, and perhaps think about using medication buccally, which certainly when you try and introduce that on a neonatal unit, everybody goes up in arms. You can't possibly do that. Well, we can, and how can we work that out? And again, drawing on charitable organisations like Rainbow Trust, which comes from a social care background, which in England will provide families with support for siblings. They'll take the dog out for a walk, they'll do some food shopping, they'll provide transport for families going to and from neonatal units and appointments. So it's about drawing on what is already there. Remember My Baby is just an example of, again, another volunteer organisation providing portraiture, and I know that there's something similar here in Ireland, but certainly this is an additional support for families. It's an additional service that we can provide. But if professionals don't know about it, they can't offer it to families. And we're also looking at how we can support within the project of development of similar senior nursing roles. The opportunity of sharing knowledge, these are just some examples where, as part of the training sessions, is knowing that in the bottom left of the screen, it's called the Butterfly Project. It's a huge amount of work that's been done in Newcastle, particularly around the death of a twin or a death of a triplet. This was a huge project that was undertaken by Newcastle University and the neonatal unit and parents. And you can go onto the website, they're developing a training package, but it's a whole lot of information that they've gathered and researched over a period of years and openly want to to share it. And I think we've certainly come to a point where we are all sharing our work. There's no point in starting from scratch. It takes time and it takes money that we don't have, and we don't have those resources. So it's about sharing what is being done. And the opportunity of sharing, there's been a leaflet that's been devised for London with parents, explaining what palliative care services are to other families. So again, this is available electronically and can be shared openly. And just in the right-hand side of the screen, I can make available the references to this, but this again is a map that I developed, built on some work done with Children's Hospice UK many years ago, which demonstrates all the neonatal units within the United Kingdom and in relation to all the children's hospices. So you've got approximately 170 neonatal units and 54 children's hospices. And if you click on any of the colours, it will show you where the details of where that hospital or that hospice is. And so it's a live Google map. So if you're looking to see where services are, it's just a resource, but again, easily shared. So the training is free. It's offered free. My role is coordinating the training. I contact the neonatal unit, find out what date works best for them. It has to work for the staff that want to access it. So the idea being that it is on site. So the training will go to one of the 30 neonatal units across London, and it's a 4-hour training session, roughly from about 8:30 to 12:30. It can be in the morning, can be in the afternoon, but it has to suit the staff and how they're able to release the staff to attend. Primarily aimed at neonatal nurses, neonatal staff, so it'll be medics, it'll be the nurses, any other allied health professionals, but the invitation is extended to maternity services, fetal medicine and paediatrics. So we cover that continuum of care. As I said, we can't be in isolation. There's no point in just having training for nurses, neonatal nurses, when doctors on that unit aren't accessing the same training. And there's lots of evidence to demonstrate the importance and the effectiveness of interprofessional learning as well. So that's where that thinking comes from. It's aimed at upskilling the workforce, because there is that recognition of the increased complexity of the babies that are surviving. And also, obviously, we have that opportunity antenatally with technology and with the investigations that are possible these days, that we can support families at the very, very beginning. It helps towards revalidation of nursing qualifications, and you come away with 4 CPD points, but the whole aim is to optimise family-centred care as much as can be facilitated. So once the date's agreed, I would go and contact the palliative care team local to that particular neonatal unit. So we've got 3 across London. So it would be one of those that they would come and speak. I would contact the local children's hospice to that unit. I would contact the local children's charities, the local children's community nursing teams. All those people would have 20-minute slots. Remember My Baby, the photographic charity, they would come, and Rainbow Trust would come, with an opportunity at the end of the session to have scenarios, share scenarios, have some real collaborative and interactive discussions around care that has previously been given to families, or I provide some scenarios so we can talk through it. And this is just a rough picture. Well, it is the picture of a template of one of the programs. So it can be as flexible, it can be tailor-made to what that particular neonatal unit want. Everybody who attends does receive a certificate of attendance, so that's their proof. And these are just some of the feedback from people who attended, saying that it was really interactive and interesting. I'm going to take back to the unit with me some of the information I've found. The networking opportunities have been really helpful. This motivates me to offer support to parents and families. And I think just that simple sentence is enough to keep going on and thinking we've probably got it quite right in what we're providing. So some of the other developments supported by the project is the development of local guidelines across London. the development of named nurses across London in individual neonatal units, and some consultants also becoming named consultants for complex and palliative care. Some neonatal units have decided to incorporate this session as their mandatory training. So there's one particular neonatal unit that has 3 of these training sessions a year. My vision at the beginning was always that each neonatal unit in London would have one of these sessions once a year, but more often than not, they're having it every 6 months. It's helping for professional development reviews. And not only is this, as I said, this project about this training and education, but it's about providing advice. People will email me or telephone me and say, look, we've got this situation on the neonatal unit, who would I call? So I direct them into the right place. And increasingly, the palliative care services they're logging and they're collating the information and the data about telephone advice that they're giving, because it may not be that it's just about a full-blown referral, full formal referral to palliative care services, but it could actually be just about having that conversation. And that's what we want, a real positive generation of having those conversations, finding out what's possible. And along the way, it's also provided incredible peer support of putting people in contact with each other about other things that are going on, or possibly similar challenges. So where we are now, as I said, this project started in March 2017. We're now 2 years and 8 months into the project, so just over 2 years to go. There's an advisory board that meets quarterly that I need to report to, and we look at evaluating the programme and moving forward. So to date, there's been over 1,000 healthcare professionals that have accessed the training. So again, as I said, that's across the board. So that'll be students, it'll be doctors, nurses, physios, dietitians, all allied healthcare professionals. And 85 sessions have been delivered, and 13 hospice sessions have been delivered as well, because alongside this training, I provide training in each of these 6 hospice services twice a year. So that's just taken on alongside that. So there's been incredible support. I'm just a lone person. It's not all about me. It is about working within a much wider team. But I couldn't move forward if I didn't have the support of the London Neonatal Network, the individual nurses and consultants and teams. Paediatric palliative care services have been outstanding because they want to get into neonatal units. They want to get into the maternity services. They want the referrals to happen as early as possible rather than meeting these families at the time of death or much further down the line. NHSBT, again, organ donation teams have been brilliant, as has the neonatal transport team. So just to end up thinking about the evaluation, at each of these sessions there's a pre and post survey that I ask people to complete. It just takes about 5 minutes. So we're in the process of collating all that data right now. Then there was a nominal group evaluation process planned in June earlier this year, where invitations were sent out to all the managers, the nurse managers on the neonatal units, to attend a session where they would look at the strengths and the challenges and possibly come out with some recommendations from particularly about the training and the project. Just recently, the last 2 weeks, the SurveyMonkey has gone out to all the participants in the last 2 years. So we're just waiting for that to come in. It's been very slow. It's been quite a drip feed of people. Obviously, it's anonymous, but you can see how many people have responded. Just to get some information about whether this training is actually being embedded into routine neonatal care. We're looking at the referrals to specialist palliative care teams, and as I said, they're also looking at the telephone advice they're providing and the children's hospices about those referrals and those professional advice information. And of course, we're getting parental feedback. So some of the strengths from the nominal group evaluation was that staff are feeling they've got increased knowledge, that the resources are free, because they are all accessible from a London Neonatal Network website, and there'll be a slide that'll come up shortly, that the information is consistent across all neonatal units. The programme is tailor-made for each of those neonatal units to be specific, but it follows the same programme. And that there is a lead person now been identified in each of those 30 neonatal units with an interest for complex and palliative care. The challenges, as always, is the time to release the staff. So even though it's a 4-hour session, it is still a challenge to release staff. And some of the recommendations that have come out is to include parent speakers, and as a result of that, what we're doing is developing a series of short DVDs where parents are explaining their stories, but also what's been helpful, what's not so helpful, particularly about introducing the term palliative care and introducing hospice and palliative care services. Some of the recommendations were also to develop bite-sized sessions, perhaps, and I've been delivering those, which are just a 4-hour session condensed into an hour, so that it can actually be possibly facilitated or accessed a little bit more easily than a 4-hour session. And then having somewhere where we can share practice. So there is the website where we share good practice and examples possibly of some guidelines or developments of resources. And the Survey Monkey, just some of the questions were, have you managed to embed palliative care principles within neonatal, routine neonatal care? Have you got increased confidence? It's just looking at trying to get another way of evaluating the training. And I've just put this slide in because the neonatal transport team did a huge amount of work in finding what was important to neonatal staff, and with their Survey Monkey they got 100% response. So clearly people are worried about how to transfer babies. So it is getting this message across widely to London. We're focusing on London now, but certainly we're looking at developing a model that can be transferable anywhere in the country or internationally. So I'm very happy to share any of our information, any of our data. This will be published when we have all the information back, but certainly it's just one model that is possible. And as I said before, the important thing is really supporting staff. This is a tough world that we've chosen to work within. It can be very challenging, it can be relentless, but certainly we need to support each other. And usually the support will come through training and education, but it's also the focus on where you get your information from. So the future developments are to develop a training package with guidelines local to that unit, providing a slide set so that the information is consistent. These DVDs we're filming actually next week with families, so these can be shown. And I'm talking about just 5-minute snippets. Nothing takes away from hearing a parent face-to-face share their story. However, we have to be realistic. I'm not going to be able to provide one parent for each of those neonatal units, each of those 30 neonatal units on a rolling programme. Sometimes in 1 year, one calendar year, I can be visiting the neonatal units 45 to 50 times because it's on a rolling programme. But also to support local training. It can't just be about me. I'm absolutely on my own, but it's about empowering other people within the neonatal units, within the maternity services, to be able to provide this very simple localized training. So there is this website. This is just another resource. It's a perinatal palliative care module. Takes approximately an hour to complete, and this is free and able to be accessed on the ICPCN website. And again, this is an additional resource. I have just put this on the slide because I help organise this conference, and you do have this within your packs. And this is the website where all the resources from the training days are available. There's a drop-down menu just on the right-hand side. It says complex and palliative babies, and we try and keep that as updated as possible. But it's an area of interest. All the information for the 6 hospices, the 3 dedicated palliative care teams and the 3 nursing teams are all available on there. So it's trying to give people what they can access and what's possible. And if you can only access the online training for an hour, then that's fantastic. It's a starting point. We need to start somewhere. Thank you. Sorry.